In this video, we're going to talk about how to investigate and manage a patient who presents to you with a leg ulcer. Once you've completed your history and physical examination, you need to decide what type of leg ulcer you think you're dealing with. And in practical terms, this means you need to ask, is it venous, arterial, neuropathic, or is it something else? Features which will support a diagnosis of a venous ulcer are location over the medial malleolus, sitting in a sea of brown skin due to hemosiderin deposition, maybe with a champagne bottle leg due to lipodermatosclerosis, and obvious varicose veins running down the medial side of the leg or the posterolateral calf. A few patients may not have much to see by way of obvious varicosities, but they will have very extensive thread veins or blue blebbing, particularly around the ankle and the foot. You may from time to time come across a patient who you think has a venous ulcer. It's sitting over the medial malleolus, it's sitting in hemosiderin, there's lipodermatosclerosis, but you just can't see a huge amount by way of surface varicosities. In these patients, consider if they have a previous history of deep vein thrombosis or pulmonary embolism, if they have a strong family history of the same, or if they have a history of previous leg or pelvic surgery. Patients who have had a previous recognized or unrecognized deep vein thrombosis may develop post-thrombotic stenosis of the deep veins. Or occasionally they will have a non-thrombotic iliac vein lesion which caused their original DVT and has gone unrecognized and untreated, leading to persistent high pressure in the deep venous system, leading ultimately to ulceration. Once you've decided that the ulcer is probably venous, you need to check the pulse status of the affected leg. So check their pedal and popliteal pulses. If the pulse is easily palpable, it's reasonable to assume they don't have an underlying peripheral arterial disease contributing to the problem. If you can't easily feel the pulses, and you often can't, particularly if they have a lot of leg swelling, then you need to check their ankle brachial index. But if you have a patient with a classic ulcer over the medial malleolus in the presence of varicose veins, their pulses are easily palpable, and/or their ABI is normal, you're almost certainly dealing with a venous ulcer and should proceed as if it's venous. So you've decided you're dealing with a venous ulcer. Now what? This is where a lot of confusion tends to creep in. I think it's really helpful to remember venous ulcer pathophysiology in terms of plumbing and pressure. At a microcirculation level, tissue perfusion depends upon the difference between the arterial inflow on the red side and the venous outflow on the blue side. If the red side decreases, or if the blue side increases, you will have reduced perfusion at a cellular level. In a venous ulcer, the problem is that the pressure on the blue side has increased. You have high pressure in the venous system, be it from varicose veins or a deep vein lesion. This high pressure in the venous system means that the difference between the arterial pressure and the venous pressure is reduced, so your tissue perfusion pressure is reduced. In order to encourage your ulcer to heal, you are going to have to try and restore tissue perfusion pressure to somewhere near normality. A common story when I first meet a patient with a venous ulcer is that they have had multiple courses of antibiotics. They've tried, or their public health nurses have tried, various ointments and lotions, and nothing seems to be working on the ulcer. And if you remember that this is fundamentally a plumbing problem, and if you remember that no lotion, potion, ointment, or antibiotic is going to affect the perfusion pressure of the tissue at the ulcer base, then it comes as no surprise that in many patients these types of topical or systemic pharmacological treatments don't really make much of a difference. This is a plumbing problem. You need to reduce the venous ulcer pressure in the majority of patients in order to get them to heal. The odd patient does heal without any intervention on the venous perfusion pressure, in which case the healing tends to be attributed to the aforementioned ointments, lotions, and pills. Although I generally try and point out to people that this is a case of post hoc ergo propter hoc. It turned out this way, therefore it was due to an intervention that there's no basis for. The key to healing venous ulcers is venous pressure reduction. The patient should be encouraged to elevate their leg as much as possible. I generally find myself in disagreement with the patients as to how much is possible. They tend to tell me that they want to put it up for 10 minutes on a footstool in the evening. I tend to encourage them to spend most of the day on the sofa with their leg in the air. A compression bandage from toe to knee is essential. This compresses the overlying varicose veins and reduces the venous pressure. You have to explain very clearly to the patient that the bandage has to be tight to do its job. Otherwise, they have a tendency to bounce back having removed the bandage because it's too tight. There is good evidence that a prompt local anesthetic venous ablation procedure for varicose veins will significantly speed up the healing of venous ulcers. And if you have reason to suspect a deep vein issue, it's worth considering a CT venogram. In addition to venous pressure reduction, there are other important management steps. If they are a smoker, they should stop. You need to check that they have adequate nutrition, and if need be, prescribe protein and calorie supplements. And check for anemia with a full blood count, as from time to time these patients will have a low hemoglobin level, which interferes with their healing. Think about an arterial ulcer if the patient has a cool leg with absent or diminished pulses. There's hair loss, trophic nail changes, and thin, shiny skin. Classically, these arterial ulcers are described as punched out and located over the lateral malleolus, although frequently in clinical practice that old observation doesn't actually hold true. A patient with an arterial ulcer has tissue loss, so by definition they have chronic limb-threatening ischemia, or what used to be known as critical limb ischemia. It's very important to understand that this entity of chronic limb-threatening ischemia is not the same as the classic 6Ps of the acutely ischemic leg, a pale, pulseless, paresthetic, paralyzed, perishingly cold and painful leg, classically due to an embolus to one of the femoral arteries. This is very different as an entity to patients presenting with an arterial ulcer, who may ultimately end up with an arterial revascularization, but do not need to go to theatre in the middle of the night as an emergency, generally speaking. Once you have decided it's an arterial ulcer, what then? Well, just like a venous ulceration, they should stop smoking. You need to check their nutrition and, if necessary, put them on nutritional supplements. And it's important in these patients to check for anemia, in that if blood flow to the ulcer is already seriously reduced, you want to make sure that the oxygen carrying capacity of what blood is getting there is maximized. At its core, though, an arterial ulcer is a plumbing problem, just like a venous ulcer. Except in this case, the aspect which is reducing tissue perfusion at a cellular level is reduced arterial flow in the red side of the circulation. So the key question that you need to answer is whether or not you can do anything to improve that arterial pressure. So the key question really is your patient a candidate for revascularization? If they are, if you think they're up to a lower limb bypass or an angioplasty, image the arterial tree with a duplex or a CT angio to assess possible revascularization options and form a procedure plan. If the patient very clearly is not fit for a revascularization procedure, you need to ask, is primary amputation an option for them? Often patients unfit for revascularization will also be unfit for amputation. But in some patients, particularly those who are already wheelchair bound for other reasons, primary amputation is sometimes a good option if pain becomes unmanageable and the ulcer does not heal. Neuropathic ulcers tend to occur over the pressure areas, so tips of the toes, heads of the metatarsals, or the tip of the calcaneum. Classically, these are described as punched out, although in my experience they are often not punched out. And they most commonly occur in diabetics, although they can occur as a complication of any type of neurological disorder. There are a couple of key things to determine if you are dealing with a likely neuropathic ulcer. Firstly, are the pulses or ankle-brachial indices okay? Particularly in diabetics, there may be underlying previously unrecognized arterial disease which will prevent their neuropathic ulcer from healing. The second question is whether or not underlying structures, in particular bone, are exposed in the bottom of the ulcer. Exposed bone is probably osteomyelitic, and even if you heal the ulcer once, it is likely to recur very rapidly unless the osteomyelitis is adequately treated. You have decided it's a neuropathic ulcer, so what to do about it? Just like venous and arterial ulcers, encourage them to stop smoking, make sure their nutrition is adequate, and rule out anemia as a contributory factor. If there is exposed bone, or if on probing the ulcer your probe is reaching down to bone or periosteum, you should arrange a foot X-ray to look for features of osteomyelitis. What are you going to do then? Well, if your patient has normal pulses, or if their ankle-brachial index is okay, and there's no osteomyelitis, they need to offload the ulcer. That means getting all the weight off it all the time, which in practical terms means getting their leg up as much as possible. If they have no pulses, or if their ABI is abnormal, you should treat them as for an arterial ulcer, as you're probably dealing with a neuroischemic entity. If they have osteomyelitis, then you are going to have to take out the infected bone. That can either be a local bone excision or sometimes an amputation. There is also a potential role for antibiotics, and the patient should also offload the area. "99% of leg ulcers will fit into this Venn diagram, either the primary circle or one of the overlapping areas. But if the ulcer you're looking at doesn't seem to fit into any of the areas in this Venn diagram, you need to ask, what if this is something else? The easiest and quickest route to answering that question is a punch biopsy under local anesthetic. Thanks for watching. Remember to like the video, think about subscribing, and the written revision notes are available free at www.vasculartutor.com.